Today's episode is with Dr. Winge. He is an emergency room physician in the UAE. He has really unique experience as he also runs a men's health clinic here in the US. He was in the emergency department here in the US for quite some time before moving over there. So we talk about his transition, our commonalities with emergency medicine, but we also dive pretty deep into lipid management. And I've brought up a couple times that it's pretty nuanced. And so he brings a unique evidence-based perspective on how he views lipid management. We also talk about the benefits of estradiol in guys and the nuances with fertility and testosterone treatment. So I'm really excited to get his information, sit down with him, and deep dive into these subjects.
All right, here with Dr. Winge. I've been following his stuff for quite a while now, and he's provided a ton of good information. He gave me some confidence to even start doing my own content because
really? Great. That's awesome. I love to hear that.
Yeah, you sit behind a mic in front of your computer and just spit knowledge the whole time. It really was
It's not rehearsed. I mean, it's pretty obvious. Not rehearsed.
And I would say you're much more eloquent than me because I realized I needed to hire a media guy to edit out all my ums and ahs, and I can't do it in one take. Sure. So you can flow in just one take.
No, I appreciate it. Thanks.
But we were kind of talking prior about your background, but I kind of want to, if you don't mind giving an intro to everybody, kind of your background as a doctor and how you've kind of gotten into this hormone space.
I'll try to keep that one short.
Okay.
So I'm a traditionally trained MD. I did all of my training actually through the military. So I went to the Uniformed Services University, and I did that for a number of reasons, but one of the biggest ones was I was broke.
Yeah.
So I took, they dangled the free education in front of me, and I was 21 years old, so I took it. So I did a total of 17 years active duty in the U.S. Air Force, both as a family medicine physician and emergency medicine. So I'm dual boarded. So I was fortunate enough to be able to do 2 residencies with a 3-year break while I was still on active duty, which I'm told never really happened. So I got some waivers, and of course it was at the height of the war in Iraq. So they needed more ER docs. So I think I was just kind of the right guy at the right time. But I would say I didn't get into TRT so much at first. I was more interested in sort of age management, health/longevity. I started getting interested in that, honestly, from like the very first day of my clinical rotations as a 3rd-year med student, because I started off in internal medicine. So we did 2 months inpatient medicine, and I was at the National Naval Medical Center in Bethesda, where the president goes for his physicals there in DC. And, you take care of just medical train wrecks in there, really sick old people. I can remember, I was 23 years old thinking like, I don't want to end up like these people. And like, is this inevitable? Am I going to be demented sitting there with a catheter, on 17 different drugs when I'm 78? I'm like, God, I freaking hope not. So throughout my traditional education, I've always was sort of, like, I had this preventive medicine bent, like mainly again for selfish reasons. Like, I don't want to end up like some of my patients. I got a little more interested in that. And then, I developed hypogonadism, and I had primary hypogonadism because which I didn't even know was a thing at the time, which was kind of embarrassing because I was a fully board certified physician. I didn't even know anything about hypogonadism, but I had a bilateral cryptorchidism as a kid, which for the listeners is bilateral undescended testes. It was not picked up on. I wasn't born in the United States. So I was born in Spain. Wasn't picked up on and wasn't surgically repaired until I was 3. So there was some damage done. So I always knew, like, basically as soon as I got into med school, we learned about that condition, that like I would probably have fertility issues, right? Because it was bilateral. So I'd have low sperm counts. But never once did they mention that, oh, you can also get low testosterone from this. Like eventually, the boys are going to get tired and they're going to give out. And that's exactly what happened. Probably, I wasn't diagnosed till I was 38, but I really became symptomatic mid-30s because something was clearly off. I didn't look like I had low T. Like in my 20s, all the way even through med school, I was competing in drug-free powerlifting. I was squatting 650, I was a pretty big, strong kid. I think I just had better than average genetics. And like, presumably I had normal testosterone back then. I could still kind of do that even when I had low T. It's just, I had this, the symptoms above the neck. The brain fog was severe, moodiness, libido was like non-existent. And I was just lethargic. But if anyone looked at me, they wouldn't have said like, oh, obviously that guy has low T. I didn't. I was still like 235, 240, basically the same weight that I am now at close to 52. So anyway, I was embarrassed in hindsight that like, as a fully trained physician, like it didn't even occur to me that I could have low testosterone. So I talked to a urologist buddy of mine, and he's like, bro, let's check your testosterone. And sure enough, I was sitting at like right around 300 for my total, but my free was really low. It was like, I don't even remember. I actually still have the labs here somewhere, like 3.7 or like 4. It was in the toilet, toilet. So I had a remarkable turnaround with, 150 milligrams of testosterone cypionate. The clouds parted, the light rays came through. It was like, and maybe it was placebo, but honestly, within a week, I was like a new man. And so after that, I was like, all right, this is awesome. This is freaking awesome. I'm going to learn everything I can about this so I can start helping other guys with it. And so that was 16 years ago. So that's the condensed version of that. Since I've been out of the military, I still work full-time emergency medicine. I'm at a level 1 trauma center. So I'm super busy in emergency medicine, teaching residents in an academic setting, but I also run a small private telemedicine practice where I do kind of my version of age management and HRT, so on the side. Eventually, in fact, probably sooner rather than later, because I'm not getting any younger, the ER shifts are not as easy as they used to be when you're in your 50s. When you're 35, you can do them indefinitely. I'm sure you can relate. But yeah, now the night shifts are getting tougher. So I'm pretty close to hanging up my ER cap permanently and then going full time into this kind of medicine.
Nice. And so you even switched from the US ER to now you're in UAE ER?
I mean, Abu Dhabi, UAE.
Okay.
So that's another long story, but I can condense that as much as possible. So my wife and I, like I said, I grew up overseas. So my dad was in the U.S. State Department. My mom was born and raised in Ireland and Australia. So I'm an Irish-American dual citizen. So I didn't move to the States until I was, I think, about 13. Okay. So, I've always had like positive feelings about living other places outside of the U.S., maybe, more so than other Americans. So, my wife and I both, like, we saw the trajectory of this country, culturally, economically, everything, and not heading in the right direction with basically no signs of it ever getting better. And so this was pre-COVID, decided like, all right, we need to kind of like, especially we were about to start a family, but now we have 2 young boys. So we thought, if we didn't have kids, you can always find some place to hunker down in the States and life will be good. But, when you have children, you start thinking, well, what's life going to be like for them? So we started looking around other places overseas, and Scandinavia was on our list, a couple other places, but I had a good friend of mine from high school who settled in Dubai, and he was always like, you got to come check it out. You got to come check it out. So we took a vacation out there. We both absolutely loved it. I did a bunch of homework on it for about a year. And then my wife was like, why don't you just put out a resume, and just see if you get some bites. And it was like multiple bites. Because that's how UAE has been so successful is, it's a tiny country with a small population. So they scour the world for talent and they bring in people who have the skills that the locals don't have. 90% of the people in Dubai, for example, are expats. They're not even local Emiratis.
Oh, wow. Okay.
India, Eastern Europe, a lot of Eastern Europeans here, Canada, a lot of people from the UK, very few Americans actually, for whatever reason. But anyway, so yeah, it was, you're a dual boarded US trained, physician with military experience, you're hired, so it wasn't too difficult to get over here. So we've been here, it'll be almost a year. So it'll be a year in August. And we love it. It's super safe over here. It's literally, Abu Dhabi is the safest country in the world. And it's been in that position, for 4 or 5 years. Crime is non-existent here. I don't lock my doors. I don't worry about locking my car. I feel like my wife is safe. She takes the boys out when I'm at work because I'm working a lot. I don't have any concerns. It's a very different society than in the U.S. And the final thing that tipped us over to get out of the U.S. was, I lived in Bend, Oregon, which is probably as idyllic as you can get in the United States, and was going to be, I always thought, like the last place that would kind of go down the tubes. And, not too long before we left, less than a year, some guy walked into the Safeway where my wife and I shopped twice a week with, with an AR-15, and I killed like 5 people in our small little town. So, and you hear these stories like all over the U.S., but now it's like in my hometown, in a very like quiet, peaceful place, which by U.S. standards has pretty low crime.
Right.
So after that, I was like, you know what? I'm out of here. See you later.
Yeah, for sure.
Yeah, that was the final straw for us.
From an ER standpoint, I mean, like, not many people really understand the ER population except for ER providers, police, firemen, that kind of stuff. Is the population still the same? Do you still have the same complaints? Still drugs?
Totally different.
Really?
Nope. I've seen, in a year, I've seen 2 people on methamphetamine in a year.
How do you even
2.
have an ER population?
Now, you can vouch, right? I would see maybe 10 or 15 a day at my American emergency department. And they would be kicking, spitting, trying to punch me, pulling knives on me. That's happened to me before. Just like complete degenerates, coming into the ER, and you have to bend over backwards to help them. Here, it's completely different. Now, the medical problems are the same. In fact, in many times, ways they're worse. The amount of heart disease, I know we'll probably talk about heart disease. The amount of heart disease over here would blow your friggin' mind. And I mean heart disease in people under the age of 35. Like, I'm routinely activating the cath lab for guys under the age of 40, and I'm doing that multiple times per week here. So there's reasons for that I think that we can get into, but a lot of heart disease, a lot of chronic kidney disease from uncontrolled blood pressure. So the bread and butter medical problems are here in a big way. They keep me on my toes. We have a lot of trauma. It's a big city, millions of people. So there's delivery culture. So all these guys on mopeds are zipping in and out of traffic, and they just get annihilated on the freeway. So I see a lot of trauma, but I don't see knife and gun, 0 knife and gun stuff. We only I rarely will have like a domestic dispute. Like we had a domestic dispute where a woman stabbed her husband in the chest. That was a huge deal here for the residents. They were all excited about it. Yeah. And back home, I'm like, oh, that's just another stabbing. Like we get 4 or 5 of those a week, no gunshot wounds and almost no illicit drugs. I won't say no because, there's every place has a certain level of that kind of stuff, but like the criminality aspects of emergency medicine don't exist here. And I'll tell you what is so refreshing. The patients are thankful, they're nice, they're appreciative, they're amazing people. I actually love taking care of the Emiratis and all of the expats. They're amazing.
The obesity
pretty cool
rate's about the same?
Yeah, it is. So it is. In fact, the Emirates, I've been speaking with a good friend of mine here, and we've been talking about this a lot. The obesity and diabetes rates are pretty high. But what you don't see here, this is interesting, and I wonder if, I haven't actually looked up the numbers to see if it matches up with what I'm seeing. The baseline, so you see a lot of people that, are in that BMI of 30 to 35 range, just for example. What I don't see is the super obese people like you see in the US. Mm-hmm. Like in the US, you go to Walmart and you see 4 or 5 people on the scooters that are 400 pound plus, the super obese. I don't really see that very much here, but the basal obesity rate, it's actually, it's higher than in the US. It's a problem throughout the Gulf, actually. It's not just UAE, Saudi Arabia, Kuwait, Bahrain, Qatar. It's multifactorial, but it is a problem. UAE is they've always been in the top 10 worldwide for diabetes. I think they were number 6.
Jeez.
So I see a lot of diabetes related, type 2 related complications.
Just kind of
taking off a lot of toes.
Poor protoplasm kind of diabetes?
Yeah, there's genetics. There's definitely genetics involved. Same with the heart disease. But also, in the summers, like right now, it's blazing hot. So, they're more sedentary here for large parts of the year. When it's 106 outside and humid,
Just can't do
you're not going to
anything.
go out for a run.
Yeah.
Like there's no time during the day where it's pleasant to be outside.
Dang.
There's a lot of refined carbohydrates and fast food. Like I said, the delivery culture, it's everything is on an app here, which is both good and bad. I can get on an app and get on this program called Talabat, and I can order literally anything I want, and it'll be at my doorstep in under an hour easily.
Jeez. Yeah.
It's
That's awesome.
amazing. So it's both good and bad. So
Right.
you can order a lot of crap food, and people do. So yeah, it's a big problem.
So we'll transition to the cholesterol stuff. So with my background, kind of acute care, ER, urgent care, truthfully, I didn't get tons of lipid. I mean, I'm family practice in P, but I didn't really focus. And then once I kind of started this clinic, I was checking it because I felt that we needed to, and I was, then I was kind of diving a little bit more into it, trying to learn more. And I've seen several of your content, but I'm going to leave it open-ended. But whenever you're checking lipid panels on these guys, are you just getting the standard cholesterol panel, ApoB, LP little a,
Good question.
CRP, homocysteine, particle sizes, all that real fancy stuff, or even more fancy?
All that fancy stuff.
Yeah. Or is LDLC enough?
Yeah, great question. Great question. If you want to be a stickler about it, really, like a basic lipid panel is sufficient for most things, like an LDLC, or you can look at like the non-HDL cholesterol, but I do get more than that. But, let's say cost is an issue for somebody. A basic lipid, I can get a lot of information from a basic lipid panel. It's not as much as I would want necessarily, but I have enough to treat you. If I do a good history and physical exam and a basic lipid panel, I can risk stratify you reasonably well. I don't get a ton of fancy stuff. I do like getting particle counts, not because of the size issue, because, that it just hasn't really panned out as a major metric that we need to be really focused on. And invariably, even though I try to explain this to patients over and over, and there's still providers out there that don't get this either, but just because you have large particles doesn't mean you're immune. Just because they're less atherogenic, like slightly less atherogenic than high density small particles, it's not like you get a free pass. But I hear it all the time, like Gary Brecker, who drives me nuts, had a video. Yeah, sorry to name drop him, but he gets under my, I watch his videos and my blood pressure goes up. And he was like analyzing somebody's lipid panel, and he was like, you know what, but oh man, but you're good because, your particle size is big, so you're really not at risk. It was just totally wrong, So I don't do it for the particle size part so much, but I like the particle count is actually, like, I'd rather have an LDLP than an LDLC most of the time. Now, in most people, they actually correlate like reasonably well, but you've probably seen it, like there's discordance sometimes. Some people will have, the machine calculates the LDLC at like 105, and you're like, oh, that's not too bad. But then you look at their LDLP, the actual particle count, on the NMR, and it's a lot higher than maybe, what you would expect. And so you're going to go with that number. You're going to treat that number, not the LDLC. So I like an initial particle count on a guy, brand new patient, and then I like an ApoB. And assuming like they don't have major triglyceride issues, or I'm not picking up like FH or something weird, I just track ApoB for the most part. You can get ApoA1s and look at the ApoA1 ratio to ApoB if you want to. That's a valid way of stratifying risk, but they all kind of give you the same information. I like ApoB because it's one number. We know it's validated in the research, and it's really, at least in the US, it's like super inexpensive. I know you can't get it everywhere. Like I do consults with patients in a lot of other countries, and they can't get ApoB there. The best they can do is an LDLC, and like, okay, that's cool. Like we can work with that, because I don't just care about that number. I really like, what's your family history? What's your lifestyle? What are your habits?
Yeah.
What's your body composition? Like all of that is as important, or probably more important, honestly, than just this one lipid number, which is just a, one data point in time. So
Yeah, and that's kind of how I,
I
it's
don't
like,
go too crazy. I don't go too crazy with it.
yeah, because you can go, yeah, you can go as crazy as you want, but then at the end of the day, what changes my management?
Is it going to, right?
Yeah.
See, I love that. I call it a decision node. Am I going to do something different because, oh, look, you've got mostly like large, fluffy LDL. Like, no, I'm not going to do anything different. Your particle count is high, and I don't really care what the density of those particles is. You're still at risk.
And so when they do have these high particle counts, do you have a kind of stair step or anything with supplements and then meds, or is it all kind of lifestyle? Or when do you start bringing in the supplements and prescriptions and stuff?
That's a great question. I've gotten a lot more aggressive with my lipid lowering just based off of what I've learned in the last 5 to 6 years from some pretty smart lipidologists. So I follow the AHA guidelines, but I tend to stratify people one step higher, meaning they'll say you're otherwise completely healthy guy, no risk factors. They want your LDL under 100. Well, if you talk to most lipidologists, most of them will say, yeah, that's fine for the guidelines, but really it probably should be under 70 because we want to shut this whole process down. Now, a lot of my guys, interestingly enough, they already come to me with either CAC scores or CTAs.
Oh, see,
So that's useful, right? Like that's pretty useful, especially if it's a CT angiogram. So if you come to me with a CT angiogram and it's like clean as a whistle. Now, by the way, that you can still miss plaque on those. A lot of people think that those are perfect tests. They're not. If the plaque is growing into the wall, you don't always see, the lumen can look pristine, but you could still have disease. So having said that, it's a pretty damn good test, right? So if you've got whistle clean arteries, we'll stick to the basic guidelines here. Let's not get crazy, but let's say you come to me with a CTA and you've got a 30% LAD lesion, which happens all the time.
yeah,
So whatever your lipid panel looks like right now, it's not good enough.
right.
Because
Flag.
as it is now, let's say it's a random 40-year-old guy, whatever it is, whatever your LDL is right now, it was enough to build that plaque. It was enough to build a 30% plaque. And so my job is that you live to age 90 and you die with 30% plaque. That's how I feel about it. Let's not make that plaque grow. And now that goes way beyond just lowering ApoB. I know the cardiologists and the lipidologists, it's the nature of their profession. They're very drug focused on that, but there's a lot that goes into atherosclerosis besides, that gradient, of ApoB. It probably is one of the most, genetics is probably the most important thing, but it's super important. I do treat it aggressively. So if you come to me and you have established heart disease, I want you in the bottom 5th percentile for ApoB, which is somewhere like 65. And the reality is most guys are going to need meds to get to that point.
Yeah.
Because they're running around. Their ApoB, if your ApoB is 130, I always push lifestyle stuff first. There's no lifestyle or meds. It's always it's both. You're not going to be in my practice and just pop pills and then, eat like an a-hole. You're going to be on a diet, buddy. But the reality is, diet alone, if let's say you got an ApoB of 130, and you need to be in the 60s, it's going to be tough, man. It's going to be tough to get there with diet and lifestyle. Now, maybe hormones might be enough to get you right there. And there are supplements that can help. So my kind of baseline initial lipid lowering cocktail, I guess, if you want to call it that, for most guys is low dose of rosuvastatin, ezetimibe, and then I like panathine, which is for the listeners, is a derivative of B5, which is pantothenic acid. It's 600 milligrams twice a day. It's been around forever. I learned about it from some Australian docs when I was in Iraq, and we talked about it. But it's about as potent as a weak statin in terms of what it does with the numbers. It raises HDL a little bit, lowers LDL a little bit, lowers triglycerides. It kind of makes all the numbers look better. Because it's a water-soluble vitamin, it's benign. You could take the whole bottle. What I tell guys is listen, this will make your numbers better, but I don't have robust outcome data on it. But you know what? It makes your numbers better, and it's completely safe and non-toxic. And I can't say that about most things that I prescription drugs, obviously. I like load like 10 milligrams of rosuvastatin, 10 of ezetimibe, and then 600 twice a day of panathine is like, if you need drugs for your lipids, that's where I'll start you. You better be doing the nutritional lifestyle stuff as well. Atherosclerosis, not to get too into the weeds with this, but it starts with endothelial dysfunction, and this is where I kind of agree with the carnivore guys in that one area. You have to have a unhealthy endothelium in order for those ApoB particles to overstay their welcome, essentially. So, how do you keep your endothelium healthy? Well, I mean, you make sure you have plenty of nitric oxide, so you're eating a diet that's rich in all the precursors. If you want to supplement with nitric oxide boosters and things like that, the L-arginine and stuff, absolutely, I'm not opposed to that. You have to lower visceral body fat. Like all those unhelpful and unhealthy hormones, the adipokines that come out of toxic visceral body fat, you've really got to get rid of those. And it's kind of funny to me, like the cardiology world they don't even talk about that stuff. They're just, they go straight for the high potency statin, straight for the PCSK9, which I get it. Like most of their patients, like the horses left the barn, like they've already got 3 stents. And so maybe it's a slightly different population than you and I see, but like I still see those guys in my HRT practice. But, the truth is like the cardiologists don't really know much about nutrition, lifestyle stuff. So it's kind of natural, I guess, that they go for the drug route. But you've got to do both. Like keep that endothelium healthy, and then, then we can address the lipids. Let's get your body fat down to 15%, and then, we can readdress your lipids. And maybe I can take you off some of these meds, which is, I like taking people off of meds if I can.
Yeah.
So,
and it's
that's kind of like my basic approach.
Nice. And I hadn't seen the panathine, to be honest. I mean,
you should check it out. I can send you some papers on it.
Yeah.
If you want.
I'll start looking into it for sure. I use like high dose fish oil, citrus bergamot. Those are kind of my 2 supplements prior to
that's
meds.
fine.
And then, I like rosuvastatin.
There's a couple.
The best of all.
Yeah. I pretty much only use rosuvastatin at this point.
Yeah.
If I'm going to use a statin. I try to keep people off of prescription drugs. I'm an MD, so it sounds like I'm pushing drugs all the time. But, let's just be real. Like, to achieve some of these goals where we know that if we can get your ApoB below a certain threshold, we can stop the growth of that plaque. And that really is the goal. We stop the growth of that plaque. Prescription drugs are necessary. People have an insane bias, like, I don't want to be on drugs. Well, okay. I mean, you don't have to be, but like, maybe you should consider it.
It's so nuanced and the media has made people scared of statins, and
Totally.
I can see
they go back and forth,
some of their reasoning, and then it's like so polar opposites. Some cardiologists think babies have a statin deficiency and push them way too much.
I know.
And then functional med guys think nobody needs a statin, and
right.
And so I do think, from what I can tell from the literature, it correlates lifetime exposure to LDL results in most of the time more plaque deposition and everything.
All things being equal.
Yep.
Yeah, absolutely.
And there are people genetically with PCSK9 on board their entire life. They almost don't develop
population.
Yeah, they almost don't develop heart disease.
They don't. No, they don't. So that tells you something right there, right? Now they still get all the other stuff.
Yeah.
But no, you're completely right. And that's why this kind of stuff the type of medicine that we practice, this is individualized medicine. And so,
exactly.
I always say, like, I don't have a dog in the fight. Like, I'm not on the full, LDL drug side of things like the cardiologist, and I'm not on team functional medicine either. Because, let's face, some of the stuff they do is a little weird. It's not evidence-based. I just want all the tools at my disposal for the individual patient that's sitting in front of me. And that's why learning about hormones is really, really important and interesting. And that's, I take estradiol for my own lipid issues. I don't have any patients on it currently. The cardiologists, and including some of the world's best lipidologists that I've listened to lectures to, I've asked them questions about this on Twitter or X or whatever. They're like, nope, you can't lower LP(a), which is, for the listeners, a super atherogenic, totally genetically mediated, kind of like think of it like as a super toxic LDL particle. But I have that. It's genetic. I got it from my dad. And the dogma is like, there's nothing you can do about it except, well, PCSK9s will drop at maybe 20%, which is true. But you just have to like do everything else perfectly if you have this. But that's not true. Like if you go into the HRT literature, you'll find that both thyroid and estradiol lower, and they lower it a lot.
Yeah.
So for my heart issues, I am on a statin. I'm on rosuvastatin. I'm on ezetimibe. I'm on panathine, and I take oral estradiol because I want to hit this from all areas. And that's where the hormones, I think, not just estradiol, but testosterone, and we could talk about peptides too. But it's not that I'm enamored with any of these particular things. I'm not a testosterone or hormone salesman. But again, I just want, in my tool belt, I want all the tools.
Yep.
I want all the tools. I want the statins. I want the ACE inhibitors, the ARBs, and I want the hormones.
Yep.
So
And you're right.
that's how I approach it.
Estradiol, I mean, you said oral estradiol. So oral estradiol specifically breaks down
Has
to
to be
the
oral.
fatty acid esters, which
Exactly.
help decrease visceral fat, which will help
Exactly.
with the plaque and everything. I mean,
Absolutely.
that's a pretty good transition to say, like, I mean, people are so scared of estradiol for the old
know.
bodybuilding literature and everything. And anytime I post anything, it's almost the only thing that gets comments is if I'm saying, don't block
I know.
estradiol. And
I know. It's a really contentious issue, man. Like people get fired up online about it. And I'm just like, all right, well, just take your AI then if you really feel like you need it. But
yeah,
like it's not supported by, like there's zero medical evidence that says you should be doing this. It's like you took away their favorite candy bar or something.
yeah. One last thing, just
Pacifier.
before I forget, you in the ER, you don't see very many premenopausal females with heart disease. And, so I think that has a lot of cardiovascular protection from estradiol itself.
I wonder why that is.
Yeah, exactly.
Yeah. And you know what's funny is even here, where again, like the heart disease is through the freaking roof, I have never had to activate the cath lab in this first year I've been here for a woman. I'm trying to think, the oldest got under 60.
Wow.
Not under 60.
Yeah.
It's all the men. It's the men who get the heart disease. The women get it postmenopausal, right?
Yep. Once they're
And we see that with LP little a levels too. Like LP little a is suppressed in the premenopausal stage. And then once women lose their hormones, lose estradiol, then their LP little a goes up. And that's why.
Yeah.
And then you put them on HRT, it goes right back down again. So.
Yeah. In one of your videos, you alluded to the AIs as being their kind of pacifier, their little scapegoat for any negative symptom with testosterone. They got to take their AI doses are inhibiting this cardiovascular protection, bone protection, erectile mood. The penis is flooded with estrogen receptors and
Absolutely.
so
Absolutely.
very responsive to estradiol. And at the serum estradiol itself does not have a lot of merit at the end of the day. It's an endocrine process. It goes in the tissues. It's just kind of spillover, maybe weekly,
It's
but
useless.
yeah, largely it's inactive metabolite. It's high to it. So, but it's hard to convince that to somebody online through text in a little bit amount of characters and everything.
So I don't routinely check it, but some of my guys, like, they just want to know. They're like,
Yeah,
can we
I'll do
please
the
check
same.
my estradiol? I'm like, all right, man, listen, but I'll tell you what, I'm not making any decisions. Like, I'm not going to change a damn thing about your protocol based on this stupid number. Okay, I know. I just want to know.
Yeah.
Like, all right, that's cool. I'm not going to fight. I'm not going to get in a fight with you about it.
I'm the exact.
But yeah, these guys, there's two big issues that I have with the estradiol thing. And it is, these guys are throwing the baby out with the bathwater for the most part. The first issue that guys need to understand is what you alluded to, that levels in the serum, they don't translate into the levels at the tissue where the estrogen is actually being used. So I tell guys, listen, your serum estradiol is whatever, it's 40. You have no idea what it is. When you take an AI, let's say you take it from 40 to 20 in the serum, I don't know what the level is in your LAD where you have that 30% blockage. And you really need that estradiol there locally to keep that from getting worse. We have no idea. Like, we'd have to go in there and biopsy you, which is not going to happen. So the level in the liver, in the brain, the kidney, like all these areas where we need estradiol, you have no idea. When you cut your serum level by 50% with an AI, you may be cutting it by 95% in the actual tissue. You might only be cutting it by 10% in certain tissues. It's an unknown. So you're just like, what are you doing? This isn't like precise medicine at all. And then the other thing, yeah, like you said, you're missing out on the tremendous benefits of estradiol, which are every organ system almost benefits from estradiol. So don't lower it with an AI. Appreciate the fact that it's helpful. And these so-called like high E2 symptoms that guys get, I know many of them get better with estradiol or with an AI initially, but the estradiol is not the root cause of these problems. So, this transient like water retention that some guys get, it goes away if you just wait it out. Or if you treat the renin, angiotensin, aldosterone system for a short period of time, which is where the real problem is, you can resolve it that way. There's all these other ways of handling these quote high E2 symptoms that don't involve lowering one of the most beneficial hormones that your body can ever make, which is estradiol. I guess when all you have is a sledgehammer, everything looks like a nail. They don't want to think to the next level. What they should be doing is like, how can I fix this water retention issue without lowering his estradiol? Because the estradiol, but instead they're like, oh, I'll just give an AI and it'll get better. And yeah, I will, but then that guy's going to be stuck on an AI for the rest of his life that he didn't need. I see that all the time. I inherit guys that have been on AIs for years, decades.
Yeah. And if you can fix their testosterone protocol, a lot of times it's because somebody put them on a junk
so that's
protocol.
The other part, right?
Yeah.
It's usually a bad protocol.
Yeah.
Right? They're blasting them with like, here's 200 milligrams of cypionate once a week.
Exactly.
And, yeah, I know you're 40% body fat and have fatty liver, but don't worry. And untreated sleep apnea, et cetera, but, don't worry. If you get water retention, we'll give you an AI.
Yeah. Perfect. Yeah.
That's what happens.
And one other kind of fallback of these
medicine.
online clinics that that do this protocol based stuff instead of individualized is I do see them fail in the fertility aspect a lot. Either fertility was not talked about at all, and they are now on testosterone at 28, don't have a family, and then you're trying to undo it. Or they sell them that, hey, you need to keep your fertility, so here's gonadorelin or kisspeptin to keep your fertility. Yeah, so can you provide some insight into why that's a bad protocol?
That's near and dear to me because, man, I'll tell you, because of my congenital condition, like I had low sperm counts. So I did think long and hard about like, okay, what is this going to do to me? When I get on TRT, and ultimately my wife and I, we had to do in vitro. I was able to stay on TRT and get my sperm counts high enough to have 3 spontaneous, natural pregnancies, but we had 3 miscarriages because my wife, it turns out, actually also had some fertility issues that we didn't know about. So we ended up going with the IVF route. So I'm acutely aware and I'm very sensitive to those issues. Even if it's a young guy who's like, I don't want kids. I'm like, dude, you're 28. Like, you don't know what you want.
It takes one partner to change their mind.
Exactly. Like, right, your world could change. Like, you walk out the door, you could see your future wife across the street. And everything you just told me will go out the window. So, I'm acutely aware of that for sure. What you said about gonadorelin is so true. And the other thing I see too is they will keep guys on, testosterone and then put them on Clomid at the same time and clomiphene. It's just not adequate. I guess the one positive thing about HCG becoming a bit restricted and no longer able to be compounded was we identified immediately all the bad clinics in the country because they were the ones that raised their hand and were like, don't worry, guys, we got gonadorelin. You take it. It's just like HCG. So I just was like, all right, you guys are clowns. Like, I'm not referring anybody to you guys. They automatically prove, like, you just declared yourself incompetent as far as I'm concerned. So that was like the only upside to it. But that's a long talk especially when I get a guy in his 20s, and we're seeing more and more guys with low testosterone. Like, I really do my due diligence with those guys and talk to them about this because you and I both know, there are protocols to restore fertility and they work, in the majority of guys, but nothing in this game is 100%. And I don't want to be responsible. I don't want to be the guy that kept you from having a family one day. So they just need to know what they're getting into. And I really, really encourage them, if possible, before they start TRT, like, let's do a fertility assessment on you. Let's at least get a semen analysis and see if there's baseline issues, which a lot of times I uncovered baseline fertility issues before they even start TRT. I'm like, we need to address this too. So, and you could bank sperm, of course. I talked to them about that. But the one caveat about banking sperm that I think guys forget about, because it seems like such a no-brainer. Like, oh yeah, man, I'll just, I'll go somewhere and we'll put it in a freezer when I need it. They can only use that for IVF.
Right.
So that's not going to be useful for IUI or any other delivery method that I can think of. So when you sign up for bank sperm, you're also signing up for a $40,000 check to write to the fertility clinic. That's what it costs my wife and I, 40 grand. And there are places that it's more expensive. I know there's ones that are cheaper. So it's okay to bank your sperm, but just keep in mind, like, you're going to need IVF if you're going to use that bank sperm in the vast majority of cases. So it's complicated.
It is, yes.
That's not like a 15-minute office visit for me. In fact, it's usually like multiple conversations. And if they want to proceed with TRT, you said like the average, like 28-year-old guy who's hypogonadal and, doesn't have any real prospects of ever like recovering good function. I will start that guy on therapy. I'm not going to let that guy suffer.
Exactly.
But at the same time, we're signing documents and we're talking and, we're making sure that we're on the same page. Because it's some guys, like, they do think that, well, I'll just get on HCG and everything will be great. It's like, no, not. It might be, but it also might not.
Yeah, and sometimes I'll still even essentially just trial HCG and a SERM to try and wake them up a bit and see if they get in a response. And if they fail, then it's much easier to go. And even if they, fail, they don't get symptom resolution, then hopefully they have a better sperm count to bank anyways. And that just kind of buys us the insurance. And that's kind of my approach to it. And I use a cryopreservation as an insurance, like you said, in hopes that I can still get it back with HCG and FSH if needed. How long if you don't mind me asking, how long were you on testosterone before you tried to have kids?
12 years.
And still successful? So that's...
But yeah. So, well, now, to be fair, though, I was on HCG for not quite a decade. Like, we tried for almost 10 years before we finally had our son. And I was on HCG that entire time. I'm trying to remember the numbers here. I'll share them with you because I don't mind talking about this stuff. Okay. I'm not embarrassed by it at all. But my baseline pre-TRT, I actually had a semen analysis and it was pretty terrible. It was like somewhere between 10 and 12 million sperm, like very poor motility, very, very poor morphology. Like, these poor guys looked absolutely terrible. They were in bad shape. I got on HCG and was actually able to maintain that same exact level for the most part. And then I put together a little cocktail of antioxidants and nutritional supplements based off some literature that I found that actually improved my morphology quite a lot. So it
really,
helped, probably soak up some of the, I'll share it with you if you want. Nothing spectacular, but it's, it improved probably like soaked up a lot of the, free radicals and reactive oxidant species and stuff like that. So I improved that. And then I got on recombinant FSH, which actually shot it up over 20 million. So like 21 or 22 million without really further increasing the morphology and the motility. So technically, for a brief period of time, I actually had what WHO calls a normal sperm count. I was above 20 million with recombinant FSH. But God damn, that stuff is expensive.
You're right. Yeah.
Thousands of dollars. So it's, sadly, like, it's out of reach for most guys.
Right.
Having a kid is expensive.
Yeah.
So, and it doesn't stop after they're born.
It just keeps going.
Keeps getting worse.
Yeah, we've covered a lot, and it's already nearing about 50 minutes or so. Just kind of wrap up.
Patience to see.
I just want to wrap, kind of, what's your favorite ED diagnosis or procedure? You see it check in and you're signing up for it as soon as you see it.
Yeah. I mean, I love cardiology stuff.
Okay, nice.
So, in another life, I probably would have been a cardiologist. But yeah, people hate seeing chest pain. I love seeing chest pain. Favorite procedure is tough. I really love doing LPs, lumbar punctures, central lines.
Really?
I had some fun a couple of weeks ago. For the first time in my career, I had a guy who had severe facial trauma, and he had bilateral retroorbital hematomas. As part of a big trauma workup, I checked his intraocular pressures because I was like, man, those eyes are looking kind of bulgy.
Yeah.
And it was through the roof. So I did bilateral lateral canthotomy
Yes.
on this I was like, even that's what I said.
Yeah.
Yeah, and the pressures of both his eyes like went right down. So I saved this guy's eyeballs. Unfortunately, he had like massive skull fractures, subdural, subarachnoid. I'd intubated the guy, had an open femur fracture. Like he was in bad shape, but that was pretty cool.
Yeah, exactly.
Bilateral canthotomies.
Yeah.
Yeah. The residents I was working with were pretty stoked about it.
Yeah, you didn't let them do it. You took those for yourself.
Well, I let him struggle for about 30 seconds.
Okay, that's it.
Like, give me that.
I mean, I'll give you that. That's a 30 seconds is a long time to watch them do it, and something you want to do it.
But it's rare enough to do one.
Exactly.
But then, like, to have a patient where you need to do two, like, that would be once in a career for me.
Exactly. Yep.
We do some cool stuff in the ER sometimes. It's usually 90% boredom and routine stuff, and then the other 10% is the fun stuff.
Yeah, butt clenching, everything.
Yeah, serious butt clenching stuff.
Yeah, so if people want to follow your content, and are you taking any more patients, and how can they get
right
a hold of
now,
you?
my practice is full right now, so I've got a waiting list. I'm in the process, it's probably a little premature to talk about this, but in the process of opening up something here, which will be a brick and mortar kind of clinic. So I've just got to find the right people to partner with and get the venture capital raised. There's a huge need for that here in the UAE. My home practice is currently maxed out, but again, as I transition out of the ER, I'm going to open it back up to be able to take more guys. This kind of medicine, I mean, I know you'll vouch for me on this. It's very rewarding.
It is.
It's really cool. You don't really change people's lives that much in the ER. We put Band-Aids on stuff for the most part. Every now and then we get a big save, but those are few and far between.
You don't
But
get to
this kind
see
of
them.
stuff,
You don't
like,
follow up after it. You
You
do
don't
it
get to
right.
see it.
You don't get that. Whereas
Yeah.
these guys come
Yeah.
back and
But like,
Yeah,
we
yeah.
changed people's lives with testosterone. We like, how many marriages have you saved? I can count like myself, like dozens of marriages and relationships were saved. Like, it's a big deal. So this kind of medicine in the long run is more rewarding. So it'll be good for me to transition into that full time. So.
and then your socials, you're on YouTube.
Oh yeah. I suck at social media. I just do. But I've got a channel on YouTube, it's called Man Medicine. And then the same thing, Man Medicine MD is on my Instagram, which I don't update as much as I should. But I try to put out, like we were talking about offline, just kind of like videos that I'm interested in. And I'm kind of a nerd. I like science. I like studies. So, I try to stick to stuff that's evidence-based and that can help not just patients, but providers too. So
Yeah.
you're not going to see a lot of like weird stuff, or stuff that's not evidence-based on there. There's enough of that on YouTube if that's your jam.
Yeah, channel's awesome. It's helped me a lot. One of your most
Thanks.
recent ones,
I appreciate that.
the oral oxandrolone and the hepatic cyst.
Oh,
and
with
stuff.
the Pileosis hepatis.
Yeah, I mean, nuts
Yeah.
that you are the one to pick that up, and then you could talk about
In
it.
the
and
ER,
stuff.
of all places. Well, that's the ER, right? You never know what's going to walk through the door.
Anytime you think
never know.
you've seen enough,
Nope.
then you'll be surprised that day,
25 years, like I'm still seeing stuff. I'm like, damn, I've never seen that before.
Yeah. All right. Well, thank you for your time. I very much had.
Cool. Yeah. Thanks for having me. This was totally fun.
Yeah.
We'll do it again.
Yeah, we will. I appreciate it, man.
Thanks for tuning in to that episode with Dr. Winge. He's awesome. Hopefully we'll have him on for more episodes. We could probably do 3 more hours of every topic: emergency medicine, men's health, everything. So we may try and discuss more later. But if you're liking this content, please like and subscribe. If you have any questions, reach out to us. If you have any suggestions for future content, of course, comment, reach out. And if you'd like to see anything specific, otherwise, thanks for tuning in for this one. Thanks.